Today, we'll be diving into central nervous system injuries, specifically traumatic brain injury, concussions, and selective spinal immobilization. Our goal is to refine our clinical judgment when faced with neurological trauma in both adults and pediatrics. These objectives align with national EMS education standards, our protocols, and current research. You'll notice that much of our focus today is on decision making, when to act, how to ventilate, and when to immobilize. Signs and symptoms will be discussed as well as an understanding the levels of head injury. Let's quickly go over mechanism, since this is something we think about on every trauma call. When we talk about mechanism of injury, we're really talking about physics meeting anatomy. Every force that hits the body has a direction, speed, and area of impact, and all of those dictate what kind of internal damage we'll see. When we think of blunt trauma, think of MVCs, falls, and assaults. The skull may remain intact, but the brain moves inside, striking the inner walls of the skull. That's where we see coup, countercoup injuries, diffuse axonal injuries, and cerebral contusions. These often present with delayed or progressive symptoms because the damage continues after the initial impact. Penetrating trauma, on the other hand, is all about the path of the projectile. It may seem localized, but remember, it's not just the bullet or object itself. The temporary cavity from the kinetic energy transfer can cause far more widespread tissue disruption. For instance, a small caliber gunshot to the temple may create massive internal cavitation. Primary versus secondary injury. Primary injury happens at the moment of impact, mechanical forces tearing tissue, blood vessels, and neurons. Secondary injury develops minutes to hours later due to swelling, hypoxia, ischemia, and metabolic cascade. As EMTs and paramedics, we have zero control over the primary injury. That's already done. But we have absolute control over preventing the secondary injury. That's where we go to work. We can't undo the crash, but we can prevent the brain from starving. Secondary brain injury comes from three main killers. Hypoxia, which is decreased oxygen supply leading to neuronal death. Hypercapnia, which is increased CO2 that causes cerebral vasodilation and increased intracranial pressures. And hypotension. Just one episode of a systolic less than 90 doubles mortality rate in traumatic brain injury. So airway management, oxygenation, and maintaining perfusion are the core treatments for CNS trauma, not the fancy drugs or the CT scan. Early recognition starts before you ever touch the patient. The moment you see mechanism, you should be forming a hypothesis. What's happening inside the skull or spinal cord right now? If you see a motorcycle helmet with cracks, you're thinking likely high rotational force. If you see a fall from a ladder, you're thinking potential cervical spine involvement. Don't just treat the patient's vitals, treat their mechanism. A patient who looks fine after a rollover might deteriorate in 5 minutes because of internal damage. Now let's get into what TBI really looks like in the field. These signs and symptoms are not just textbook, they are your red flags hiding in plain sight. Here's the challenge with head injuries though. Not every TBI looks like a dramatic scene from a trauma show. Sometimes it's just a patient who seems off. You might see someone talking clearly, answering questions, and then they suddenly repeat themselves or lose track of what's going on. That's your cue. Physical symptoms are the ones we're best at spotting. Headache, vomiting, dizziness. But don't overlook fatigue, light sensitivity, or numbness and tingling. Those are subtle and often brushed off by the patient as just adrenaline. If your patient is stumbling or seems clumsy, that's not just balance, it's neurological miscommunication. These are the silent injuries: fogginess, slowed thinking, difficulty remembering, all signs that neurons aren't communicating properly. Ask simple memory and concentration questions. We use ANO times 4, which is person, place, time, and event. This is a good start, but requires deeper questioning. We want to ask these patients to remember something such as a red ball, then talk about something else and come back to the ball and ask what color the ball was. Next, give them questions about money, where you can ask how many quarters are in $1.50. It's not about passing a test, it's about how long it takes them to respond and give clues to brain function. If they pause, look confused, or give inconsistent answers, that's your clue. A documentation tip for everyone is to make sure to document delayed responses, even if the answers are correct. That delay might be the first indicator of intracranial swelling. Fatigue and sleep changes are underappreciated in acute EMS care, but crucial for education. A patient who's excessively sleepy or hard to wake up post-injury should be assumed to have rising intracranial pressure until proven otherwise. If they're getting harder to arouse, that's not rest, that's deterioration. Even if you're clearing the patient from home observation through a refusal, stress that sleep disturbances can indicate worsening pathology in the hours after impact. In kids, TBIs often look like mood swings, irritability, or loss of interest in play. In the elderly, confusion or imbalance may be mistaken for dementia or intoxication. That's why knowing baseline is vital. Ask the family, is this normal for them? The key for us as EMTs and paramedics is pattern recognition. These symptoms don't exist in isolation. Headache plus confusion plus irritability are red flags. Fatigue plus nausea plus confusion, red flag. Always consider mechanism, repeat assessment, and involve family or bystanders for timeline accuracy. All right, let's talk about everyone's favorite, or maybe least favorite, neurological assessment tool, the Glasgow Coma Scale, GCS. We all know the score, but the key isn't memorizing numbers. It's understanding what those numbers are telling you about the brain in real time. The GCS remains a gold standard, but we must treat it as a trend, not a number. A GCS of 13 that drops to 10 is an emergency. Always reassess after interventions like airway repositioning or oxygen therapy. The GCS was designed to provide a universal language for describing a patient's level of consciousness. It helps us communicate clearly with ER staff and trauma teams. They can picture the patient before they can even see them. When you call in a GCS of 8, every trauma provider knows this is a patient who needs airway control now. But remember, GCS is not the full story. It's a snapshot in time. The real clinical power is in the trend. You can have a GCS of 15 and still have a life-threatening injury developing under the surface. The first GCS gives you a baseline. Every reassessment tells you whether your patient's brain is improving, stable, or deteriorating. If your GCS drops by 2 or more points, that's an immediate red flag for rising intracranial pressure or hypoxia. A patient who goes from a GCS of 13 to 10 hasn't just gotten sleepier, their brain is swelling or they're losing oxygen. So a field tip is to always reassess GCS after every major intervention, which is things like airway repositioning or intubation, oxygen administration, blood pressure changes, or any medications or sedation. When we interpret GCS by category, we basically have 3 sections: minor, moderate, and severe. Minor is the 13 to 15 range, often called a mild TBI or the concussion range. The danger here is complacency. These patients can look fine but worsen rapidly. Watch for confusion, repetition, and delayed response times. For moderate, 9 to 12, that's considered the gray zone. These patients may protect their airway now, but are at high risk for rapid decline. Early airway planning and continuous reassessment are critical. In severe, which is 3 to 8, this indicates coma or deep unresponsiveness. Airway and ventilation are immediate priorities. Expect loss of protected reflexes such as gag, cough, swallow, and the potential for herniation. It's easy to misinterpret GCS when other factors are in play, such as drugs, alcohol, shock, or hypothermia. These can all lower the GCS without true brain injury. But here's the key. Even if the GCS is artificially low, treat it as real until proven otherwise. The ER has CT scanners. You only have your eyes and your judgment. In pediatrics, verbal and motor responses vary by age. Crying, cooing, or withdrawing may be normal for a toddler. In geriatrics, baseline dementia or stroke deficits can complicate interpretation. Always ask the family or nursing staff or caregivers, is this their normal? The GCS is only valuable if you communicate it properly. When giving a report, say a GCS of 12, eyes to voice, confused speech, localizes pain. That paints a picture. Don't just say GCS of 12 and move on. The GCS isn't just a score, it's the story of the brain's decline and recovery. Your job is to recognize when the story changes and act before it ends badly. Ventilation is one of the few things we directly control in head-injured patients that impacts secondary brain injury. So we need to understand what we're doing and why we're doing it. CO2 is a major driver of cerebral blood flow. High CO2 dilates cerebral vessels, which increases intracranial pressure. Low CO2 constricts vessels, which reduces cerebral blood flow, which can worsen ischemia. So ventilation is a balancing act. We're trying to control ICP without starving the brain of oxygenated blood. Our goal is normal to very slightly lowered CO2, not aggressive hyperventilation. Historically, we were taught to aggressively hyperventilate every head-injured patient. We now know that this can worsen outcomes because it decreases cerebral blood flow too much. So the current goal is an end tidal between 35 and 40 if no signs of herniation, and 30 to 35 only if we are managing known elevated ICP or suspected herniation. This is mild, controlled, and guided by capnography, not guesswork, not just bag faster. We do not hyperventilate TBI. We only consider mild reduction of CO2 if the patient shows impending herniation. So signs of herniation. You have unilateral blown pupil, posturing, which is decorticate or decerebrate, rapid drop in a GCS score, and Cushing's triad, which is increased blood pressure, decreased heart rate with irregular respirations. If those are present, target your end tidal CO2 between 30 and 35. If not, then keep it between 35 and 40. Hyperventilation is a temporary bridge to definitive care, not a cure. If using BVM, use the two-person technique if possible. One person delivers one breath every 6 seconds. Watch end tidal CO2 waveform, shape, not just the number. If you don't know what a waveform should look like, then grab your closest paramedic and have them explain and show you this in detail. Avoid squeezing aggressively. Volume should be just enough for chest rise. Remember, a perfect SpO2 with a bad end tidal is not fine. Oxygenation and ventilation are different issues. If the brain is swelling, it needs oxygen and blood flow. Our job is to prevent hypoxia, hypotension, and CO2 extremes. Controlled ventilation saves neurons, not aggressive bagging. Spinal management has changed dramatically in the last decade. There was a time when every trauma patient got a backboard, a collar, and tape, no matter what. Research now shows that routine long backboarding can do more harm than good. So the modern approach isn't immobilization, it's spinal motion restriction, or SMR. SMR means we are protecting the spine by controlling movement, not by forcing rigidity. This may include a C-collar or verbal coaching, which is saying things like, don't move your head, keep looking forward, or it can be padding and positioning for comfort. Self-extrication rather than dragging or lifting when possible in many cases. The stretcher is safer than a long backboard. So how do we make an informed decision on spinal splinting or not? Our protocols give a great algorithm for this. On the bottom right side of this slide is a list right out of the protocol. This is based off the Nexus criteria and says that if a patient is impaired, whether through intoxication, recreational drugs, distracting injury or illness, or unable to make rational decisions, or if there is a behavior to evaluate the patient, whether it's a language or developmental barrier, or if the patient is greater than 65 or less than 5 years old, or if you find neurologic deficits such as numbness, tingling, or weakness, or the patient has midline tenderness to palpation, especially if it's pinpoint tenderness, then this patient will, at a minimum, get a C-collar. When you continue your assessment and find that the patient has obvious motor or sensory deficits, or they are unable to follow commands, then they will get spinal immobilization. This does not necessarily mean a backboard though. This can mean an ambulance stretcher, a vacuum mattress, scoop stretcher, or as a last resort, a backboard. I would encourage everyone to review this protocol and discuss what has gone well or not well while on scene with different calls. For me, I've had it both ways where we splinted when we needed to and didn't splint when we needed to. First was a call on Highway 115 where the patient was in a head-on collision and was so upset about having his new car wrecked that it was difficult to calm him down. He was pacing and obviously upset. He had an abrasion to his knee and no other injuries found or described by the patient. I had a feeling that we should put him in a collar and get him on the stretcher, but it was a difficult task. He did get transported, and we later found out that he broke his back in 2 vertebrae and fractured his femur near his knee. So that is an example of when we should have splinted but didn't. Next is when I did splint, but the ambulance had a different opinion. We had a 78-year-old female that was in a minor fender bender on Titus. She broke her nose on the steering wheel and said that her neck felt sore and her hands were tingling. I placed a collar, and when the ambulance arrived, they ripped the collar off and threw it across the street and said some pretty crazy stuff about the fire department. When the patient got to the hospital, they found that she had in fact broke her neck and was very lucky to have not made it worse. That paramedic was later fired for this and other stuff, but that's a story for another day. This is an example, though, of why it is so important to understand why we do what we do. Next is where to take these patients. Transport destination guidelines for trauma are in our protocol. After class, review these because they are in depth. A basic takeaway is that if it's serious and it's pediatric, then they go to children's. If they're an adult, then they go to Mimo or Penrose, Maine. But there's a very good breakdown of what is allowed and not allowed at each facility in our system. When patients refuse transport, education becomes your best tool. Take 2 minutes to explain red flags. It could save a life later. So now, let's bring everything together. When we talk about CNS injuries, remember that the primary injury has already happened before we arrive. Our role in pre-hospital care is to prevent the brain and spinal cord from getting worse. That means every decision we make, how we ventilate, how we position, how we communicate, how we transport, is protecting neurons. Secondary injury is the enemy: hypoxia, hypotension, hypercapnia. These kill brain cells after the initial trauma. So your early assessment is not just documentation. It guides what happens next. The earlier you identify changes in mental status, pupils, or neuron function, the earlier you can intervene and prevent long-term disability. If we keep the brain oxygenated and perfused, we are actively saving brain tissue. Capnography is not just for respiratory patients. In a head-injured patient, end-tidal CO2 is how we safeguard cerebral perfusion. Too high equals cerebral swelling, too low, ischemia. We target 30 to 35 only when we need to control suspected ICP elevation. Otherwise, keep them at 35 to 40 and ventilate gently and deliberately. Every squeeze of the BVM changes their ICP, bag with a purpose. We don't just treat patients, we treat families, coaches, teachers, and bystanders. A concussion patient who refuses transport may seem fine now, but can deteriorate later. So your explanation may be the only medical guidance they receive. Teach them what warning signs to watch for, when to seek emergency care, why rest and gradual return to activity matter. This is just as important as the hands-on treatment. The words you say on scene can prevent catastrophe later. We no longer throw everyone onto a backboard. Why? Because unnecessary mobilization can cause pain, respiratory compromise, pressure injury, increased agitation, which equals more spinal movement. Instead, we use spinal motion restriction, SMR, thoughtful positioning, verbal coaching, and when needed, a C-collar. The question is not, did they crash? The question is, do they have signs or symptoms of spinal injury? Protect the spine with your brain, not just your equipment. CNS injury management is not dramatic medicine, it's careful medicine. Small decisions make big neurological differences. Every choice we make either protects the brain and spinal cord or harms them. For discussion, I want everyone to review the spinal motion restriction protocol and the transport destination guidelines in our protocol and discuss what has gone well or not on scene. Next is to discuss what is one thing you will do differently on your next head injury or suspected spinal injury call based on today's discussion. So have fun with that.